Morning, everybody. Hello. Good to see you all. I'm Kristen Bates. I'm the Deputy Medicaid Director, and I also run the state Medicaid and CHIP Office of Behavioral Health Initiatives and Coverage. What that means is me and my colleague Melissa here run most of the behavioral health policy for Medicaid here in Colorado. So we're going to talk a little bit about what I think most people have been asking me about the past, 6 months or so. And we called this Bracing for Impact, right? I think what's important to understand about what's happening in Medicaid and financing right now is that we're all going to be impacted in the next, I would say, 2 to 3 years. By some of the changes that are coming down federally from Medicaid, as well as some of the improvements that we've been making to Medicaid and expansions, and how those are going to be retained. That's the goal, retaining the progress that we've made. I'm going to go through a couple slides here. I think we're going to talk for about 20 minutes. We have 40 minutes today because we really want to take your questions. So Melissa and I will go through about 10 slides, and then I didn't even make an agenda slide. So we got short number of slides, and then it's really up to you all. So what are the challenges that we're facing? Why are we having these financial challenges? There's really 2 reasons. So one is, even if H.R. 1, the bill that made a lot of changes to Medicaid at the federal level that was passed in August, even if that hadn't gone through, we would still be facing challenges in Medicaid. And part of the reason for that is just generally how healthcare inflation works. The cost of healthcare is going up faster than the allowable revenue for the state. That's the basics. Now, the reason for this, even though Colorado is economically doing very well, is because we have something called the Taxpayer Bill of Rights here in Colorado. One of the only states in the country that has this. It says, your tax revenue can only grow by this special magic formula that was written into the Constitution. I mean, it's very difficult. The only way to change this policy from the 90s is through a ballot initiative. And when it came out a few years ago, it did not pass. So we say, listen, here's the growth of revenue, and even if you get more people coming in, even if you get more money, we want to make sure that the government is growing at a steady rate. Well, that's very reasonable, until you realize that the growth of healthcare costs and the other things that the government pays for here in Colorado, like childcare costs, food costs, are going up at a much higher rate than that special magic formula. And so what we're looking at is 40 years, no commercial or Medicaid health plan has been able to maintain that level of growth. We grow about 8% a year, and we need to be about 3 to 5%. So what that means is every time we grow at a higher rate than the cap in Colorado of revenue, we're going to have to be taking chunks out of our own projects or out of other people's projects, right? Education, roads, childcare, all of these things, right? So we're really at a state level in a place where we have to say, listen, we can manage our budget. We have a balanced budget. But at the rate of growth, we're having to cut because the growth is going to be higher than we can manage. There are plenty of seats up front if you guys want to come sit. And there are lots of seats over here as well. What else is going on fiscally? Well, we also had all this PHE money, the public health unwind, which was incredibly difficult. Again, Medicaid challenge in Colorado, where we went from about 1.7 million members to about 1.2. But we had some federal stimulus dollars that were basically to say, we know COVID has an impact, and so we're going to give out grants to help build capacity. And build capacity, we did. You all did that, right? You all used the opioid money and some local funds and some state funds and some county funds and some city funds, and we built our ability to provide substance use and mental health services in Colorado. So I think the challenge now is anything that was relying on those grant dollars, those are gone. So now, what's the sustainability pathway? From a state level, Medicaid, Behavioral Health Administration and the opioid funding. That's the money, that's the pot. And so now we have to make sure that we're able to continue to do this. What else? So what is it about HR 1 that's changing? So the federal policies that really make an impact on Medicaid, there's a couple of them. But the main one is changing the way we determine somebody's eligibility for Medicaid, right? So it used to be, you know, as long as you meet a certain income threshold based on your household size, that's one way you meet Medicaid requirements. And then the other way is you're a child or a person with disabilities who meets it by way of like your illness status or your disability status or your age. Or, you know, being pregnant. So those are kind of traditional Medicaid and then expansion populations. The change that's happening is that instead of doing annual determinations, so like right now in Colorado, if you are on Medicaid, you get to stay on Medicaid for 12 months, and then after that you reevaluate if you're eligible. They're gonna do that every 6 months now. That puts a ton of pressure on the counties, and you also have to think about every time somebody makes a mistake in paperwork, which happens, and we try to make that as low as possible, but that means there's a higher likelihood of margin of error, higher likelihood that people are going to either the people who are making the eligibility determination are missing paperwork, the person is missing paperwork, there's some kind of follow-up email that goes to the wrong email address. I mean, all of these little things happen. And then the other piece is the work requirements. So this is the rule of 80 that says you have to spend at least 80 hours in the past month volunteering in an education program, certification program, or working. And again, that only applies to the expansion population. So again, people with disabilities are out of this. Kids, obviously, are out of this. But even like, if you're a parent of a child, like, it only goes up to 13 that you're exempt. So these are the things where we're gonna have to take money out of our medical services line, which is how we pay communities and providers, and we're gonna have to put it into administration. So this is increasing the administrative workload for both Medicaid members and for counties and for the state. And that money all comes directly out of our total amount, and that means we're having to cut programs. So that's what the challenge is. I think there's a lot of hard parts about working for Medicaid right now and working with the Medicaid population, you all know. But the idea that we have to put in all this work and the end goal is fewer people get Medicaid, that feels gross, right? That feels like bad in my stomach, because all of us who work for Medicaid pretty much like, we do this because we think it's an important program. Hopefully you guys find it to be an important program as well. Thank you. So we are doing our level best to try to figure out what are the least disruptive ways to cut, what are the most fair ways to cut, and that's what we're gonna talk a little bit about today. Let's see, what else do we have here? The other thing that we're gonna see though is like increased uninsured rates, right? So as fewer people on Medicaid, that puts a different kind of pressure on safety net providers especially. And those are folks who have to see individuals no matter what. Federally qualified health centers, comprehensive safety net providers, hospitals and emergency departments, and then also just your safety net providers who are safety net because they choose to be, right? They're not any kind of special designation, but they know that the work that they do saves lives. And those folks are gonna see more people and have to make choices. And again, that's gonna be really difficult. So we're trying to partner with, you know, community partners, the Behavioral Health Administration to try to make that impact as limited as possible, but that's what's going to be disruptive, right? You're gonna have more people who are uninsured. So increasing your uncompensated care, and so that just shows up as, guess what? More healthcare inflation. So it's like, I don't know, you know, you squeeze the balloon, it shows up somewhere else. These cuts are gonna show up in our communities. So I think the other piece is the IT investments. Like I said, that's administrative, and really what we're trying to do is we're trying not to hit a single type of provider too many times. We're trying not to cut entire populations of people. We're trying not to cut entire programs. So we're trying to be a little bit more thoughtful about that. So what is behavioral health safety net? What does this feel like to you? So this is my thought and my recommendation at this point. If workforce requirements are gonna be what pushes people out, Partner with workforce programs. This becomes not only the dignity and economic stability that comes with jobs, which what's cool about behavioral health is, unlike a lot of other healthcare areas, we know how to do this. We've been doing supported employment for years. We've been doing employment programs, vocational rehab. How do you go to work when you're still having anxiety? How do you go to work when you have criminal justice, like a history, you have something on your, how do you get a house? We've been working with this for a long time. You will have skills that a lot of others don't. And the behavioral health system, through substance use, especially through these supported employment programs and through peer support training and recovery programs, keep building those partnerships, keep building those relationships to help get people placement. If you need volunteer services, all of a sudden, becoming a volunteer is not just work and purpose, it's coverage. It's maintaining your medication-assisted treatment. It's preventing those uncompensated care costs from going up. The largest cut that you all will feel will not be to a program. It will be to the total amount of people that have Medicaid, right? So we're going to go down again. So we went from 1.7 at the apex, and now we're going to hit a much lower level in the next 3 years. Here's the other thing about behavioral health, though, on the downside. People who receive substance use treatment from Medicaid in Colorado, a majority of them are expansion population. So again, like I said, if you are a child or a person with a disability, then you are exempt from these workforce requirements. But a lot of the people who are on Medicaid and receiving substance use services and mental health services are expansion populations, so they're at the highest risk. So they're the ones, so that's the other piece, is that your populations are at greater risk of being reduced than other conditions, right? So I think the other thing is wraparound services become a risk because other smaller agencies that are relying on PHE or COVID money, or hospitals were giving them money and now hospitals have to keep their money for their uncompensated care. That's what it's going to feel like. So here's what we're trying to do. In the last 5 years in Colorado, we've made extraordinary strides. And I want to thank all of you. We have doubled the amount of people accepting Medicaid for behavioral health services in Colorado. We have increased access to care by 41% for behavioral health services in Colorado. And we have doubled our Medicaid budget from $600 million to 1.2, and next year it'll be $1.4 billion. Those are investments that the state has made. So what are we trying to do? We're not trying to go backwards. We just got to maintain. So that is the goal. What I want to show you guys is, this is what expansion looks like, right? And I'm not trying to show you this so you have to get out your bifocals. I'm showing you this so that you can see the rate at which things are increasing, right? So what we need to move from is, 23%, 300% increases in trends. That is not sustainable. But if we can partner together, we want to hit this plateau. What we want to do is we want to go from expansion, which was expected, budgeted, and planned. We planned for this expansion. And we want to make sure that we hit this plateau, which means we're going to even out, we're going to retain the gains that we've made, and we're not going to have to make cuts. But what I need from you all is help with some of the fun things, like audits and extra paperwork from Medicaid. I'm very sorry. That's just what it's going to look like. And Melissa's going to talk a little bit more about what those activities are that you can help us with, and then we'll start. We've got about 7 minutes, and then we'll start taking questions.
Just gonna do this, guys. They don't make it for short people. In fact, I might stand outside of the podium as well. Life is unfair sometimes. Melissa Edelman, I work with Kristen, and just wanted to talk to you guys a little bit about the drivers of trend that we're trying to address within Medicaid. And we have this sustainability framework that we're working with across kind of HICPUF. And some of this, to what Kristen was saying, happened well before HR 1 when we saw some of the problematic trends that were happening in Medicaid, and even before that for us in behavioral health. So every year we go and we set capitation rates for our regional accountable entities, specifically for behavioral health services. In the last 2 years when we've done that, we've seen unprecedented growth in the capitated behavioral health program. Some of it is actually, to what Kristen said, absolutely expected. We invested for it, we planned for it. And some of it is trends happening outside of what should reasonably be expected for the program. And so that lends to a few different things. That might mean our folks aren't connecting to the right levels of care. It could also mean that maybe providers are not using the correct services when they're providing, and we might need to do a little bit more definition around what the appropriate services are that should be billed for the type of care that's being provided. And then unfortunately, for some of it, there's nothing more that can explain it other than fraud and abuse. And so this isn't a one-prong approach to how we're dealing with this across the department. So one of the things that we want to do is we want to look at our program and are things happening the way we expect them to. The other places, are we hiring certain types, or sorry, paying more for certain types of services than we expected to? And again, determining if that was appropriate or if there's actions that we need to take to kind of address some of that outlying trend. And then looking for opportunities to draw down additional federal match dollars. Kristen's going to talk a lot about this a little bit more. I say a lot. She's going to touch on it on our 1115 efforts and the way that we're trying to potentially draw down additional money in the state. But also, we are exploring a CCBHC, that's a Certified Community Behavioral Health Center grant. We're in a planning grant right now, and we hope to go into a demonstration grant starting in July, which will allow for a short period of time, 4 years, for the state to pull down some additional dollars. There is definitely a way to do this to make sure that we're not creating another funding cliff like we did with the ARPA dollars. So we're investigating how to do that as a state in a sustainable and appropriate way. And then some of it is like precision cuts. There's not one specific type of group. We're looking for ways to kind of streamline billing for providers, also looking for opportunities to reduce administrative burden when we know that the money's not going to always be there. Are there ways that we can do do services more efficiently in a way to make our money stretch a little further? All right, so here's just some examples of some of the reductions that are happening for fiscal year 25-26. None of these actions are like, none of them are capricious or would it be easiest if. They're all very data-driven kind of decisions that we've moved into. And to Kristen's point, the idea is to figure out how to run the program more efficiently so we're not reducing the folks that can receive the services or the types of services that folks are able to get access to. And then we hit on it a little bit, but really planning for the future, looking for opportunities to bring down additional money within the state. You all know that we're working on our transition to ASAM 4. We see this as a more efficient model of providing services that really it lends to fewer opportunities for people to fall in between the cracks between withdrawal management and residential treatment, but additionally puts a lot of continued emphasis on that discharge planning and really connecting people to care on the other side. So figuring out ways that we can, again, bring more efficiencies into the system. And then one of the other things that we've had difficulty around the state is really wide variations in inpatient rates across the state for what it is to the amount of money that it costs to provide services in different areas around the state, but also across different levels of care. So whether that be a general hospital versus one of our freestanding psychs, for instance. Some of you might know we instituted a new prospective payment system for our certified, comprehensive safety net providers in last July. And so we're looking for ways to make sure that the growth within that model, that payment model, is appropriate over time. And then I'm going to leave the 11-15 reinvestment fund for Kristen to talk to you guys about.
This is just anticipating the question that I get around the non-HR 1 federal changes. Is Colorado going to be able to keep our 11-15 waiver? And the answer from our perspective right now is absolutely, right? We do not see this as a high-risk federal change. I will say the amount of states that rely on services that are provided through an 11-15 waiver, and what that 11-15 waiver, that just means it's federal, they like waive certain federal requirements to provide services in a particular kind of way. And our federal partners at Medicare, Medicaid services say, if you don't do it, if you don't meet our rules, but you don't do it in this way that we approve, then it's okay. And so that's kind of like the inmate exclusion policy in 1965 when Medicaid was created. They said you can't pay for any services that happen in a jail or a prison or in an institution. An institute for mental disease is what they call a residential substance use provider, and they still literally use that language, which is very bizarre to me, but like get with the times. But we think that we should be able to keep our SUD services, which are funded through an 11-15 waiver, but also the expansions that have recently been made, which is services for criminal justice transitions. So starting to reimburse jails and prisons for 90 days prior to exit for specifically medication-assisted treatment, 30 days of pharmacy upon release, and care coordination, and evaluations and assessments. And then the one thing we did lose, though, this is the big bummer, which was, I think we changed. There's a slightly different version of this slide. We were going to get continuous eligibility, which means that for 12 months after you leave a prison, we are going to be covered by Medicaid and children 0 to 3. Because if you need it at any time from the ages of 0 to 3, you need it the whole time. They did pull the continuous eligibility, which we hadn't implemented yet, so you guys won't feel it. But us policy nerds and the people who were hoping for this are going to feel it. So what we do anticipate to keep going, though, health-related social needs, coverage for housing vouchers. So that allows our housing voucher programs, especially these include behavioral health vouchers, go further, longer, paying for transition services, for moving services, for helping somebody get leased up, for tenancy support services. We're going to be paying for that. We're moving into nutrition next year. And then also the big one is, for a long time, we've only been able to pay for 15 days of mental health treatment for people who are seriously mentally ill with a lot of times chronic, like SUD, homelessness. It might take you longer than 2 weeks to stabilize in a hospital. And the thing was, if you were there for 16 days, Medicaid would pay you nothing. There was nothing we could do about that. October 1st, we can now pay for up to 60 days. Now, the total is still going to be under 30 days, and most people stay in a hospital for like 4, but that's a big one for us as well. So we did get an extension on this for 1 year. We asked for 5 years. They gave us 1. Okay, we'll take it. Hopefully they're not plotting against us, not to be a conspiracy theorist. But hopefully that is going to lead to ongoing. So I think that that's the main question I've been getting also from these folks, so I wanted to answer that one. But with that, I think we have 2 mics. And if we could just take some questions. Melissa, you want to come up here? There's an extra mic right there. You want to turn it on? Questions. I will even take, I don't have a question so much as a comment. Like, I'll accept it. We got a couple folks over here. We do need it because of the recording. Here, Melissa, you want to hand her the mic? There we go.
On one of the slides, you said sustaining Medicaid in new budget realities.
Yeah.
One of the ones I saw on the top left, which is really important to me, is limiting peer support scope. My question is, where is that determination being, where is that being determined, and who is at the table? It's not that I'm not against the regulation of peer services and knowing what that is, but you've given, like, Medicaid, we got a general code of 80038. We had no instructions on what that was supposed to look like. Now we're being told it's going to be pulled or cut in half. And so my question is, and we've seen it being done fraudulently. I've been really bold about that in the state, speaking about not all peers are doing real good peer work and are taking advantage of an offering payment system. But I want to know who's at the table helping you decide what that limiting peer support scope is, so that we make sure that the most essential and critical of peer support is actually saved. Because we do know that it has been abused in housing all across the state where it wasn't supposed to ever be used in the first place. I hear there's vouchers, that's cool. But our peer support services have been abused for that space. And so I just want to make sure that those of us that are actually doing that work, because it feels very disconnected. It feels like this was all created without people who actually do the work to create it. And so I just want to make sure, and I'm somebody who's willing to sit at that table, making sure that that limiting peer support scope actually does something impactful or doesn't destroy the entire peer community.
So, very nice. So I'm going to let Melissa talk about, thank you very much for that. I'm going to let Melissa talk a little bit about medically unlikely edits, but I'm going to say a couple of things about peers to start. The people who were telling us about the peer concerns outside of our data, and the data on this is in this bottom right here, where we went from less than $5 million to over $20 million. And these are 3 different codes, right? So we've gone from almost 100% increase every year. Now, anytime you're making cuts to Medicaid, it's difficult, and it, again, from a public health background. But I will say the people who brought this concern to us are other peers, are other providers. And I appreciate that. And I want to thank you all for coming and making these tough decisions and saying, hey, I'm concerned about what's happening at, my job might be at stake, but I can't stand by this, right? And we have had some contracts terminated based on fraudulent behavior. I think what's exactly needing to happen, though, is what you're right about, is we let this out. We did not do enough education on what's allowed. And so we opened the gate. We didn't build a fence. Now we're building a fence. So we have Colorado. I want to shout out to Colorado Providers Association, right? Yeah, Precious knows, like, and I think that they've been really helpful in trying to say, hey, listen, where is it that we need education and provider support? Versus where is it that we're concerned about actual fraudulent, and when is it that somebody's doing something that is not allowed, but they're not doing it on purpose, they're just doing their best. Like, where can we bring them back into, hey, listen, as long as you do it this way, it's gonna be okay. We did cut some of the places where it's allowed, and then we cut, I think, the total amount of hours that can be a day. So Melissa, can you talk about where medically unlikely edits come from? She taught me about this recently.
I don't know why anyone trusts me with technology, folks. Federally, there's an initiative called the National Correct Coding Initiative. And there are basically federally, CMS and some other partners get together and they're like, how likely is it for certain things to happen on the same days? And so there are procedure-to-procedure code edits that say these 2 services shouldn't happen on the same day. And then there are medically unlikely edits that says it's very unlikely anybody needs 10 hours of peer support services a day. Is just an example. Or there's like a brief therapy code where if you try to bill for 15 units a day, CMS says that's not brief anymore, right? And so those are some of the things that we're trying to apply to the program when there is that kind of national standard. Medicaid programs are supposed to require all of their bill claims payment, goes through those edits. That's a requirement for state Medicaid programs to the federal government. And to go around that, you have to actually get special permission from CMS. So then Colorado's creating Colorado-specific MUEs for types of services that we are seeing, again, happening in a manner that is not consistent with the procedure code definition. So for instance, like a skill building service, right? Where you're getting 6 hours of skill building a day. My question to you is, would psychosocial rehab be a more appropriate service for this individual? And so you'll see some of our efforts coming around on providing greater code definition. When we say this code, this is what we mean for skill building versus this is what we mean for psychotherapy. Skill building, right? You should probably maybe 4 days or something of this. It's not supposed to be long term. Like there's a skill that it was determined. Yes. Yes.
Collaboration of language.
That's big.
Yes.
Challenge why we want to be at that table is because translating that to us, y'all are clinical. We were built into a clinical system that does not make sense to us. It's why it's not working, right?
Yeah.
So it's like, how can, back to that system conversation we had in the big room, how do we work along systems? Get us to the table. Let those of us doing the work out in the world that are doing it well, mind you, help you do this better.
Yeah. Absolutely. I will tell you, some of these changes did come down very quickly in the last 6 months of last state fiscal year. So probably from about January to July. We did try to work with COPA. We tried to work with the RAIS and the Behavioral Health Administration on creating a policy that made sense. We know we have more work to do now that we have more time. We have made a commitment to COPA that we will actually try to work with them on our messaging on language because to your point, we put out something and it makes total sense to us and we need to do a better job of using the right language. So COPA is going to help us with that to make sure that what we're saying makes sense to folks in a way that is meaningful to them. And it's not like this high-level understanding of what's happening in the system, but really breaking it down, what this could mean for you in your practice. Because we haven't been messaging the right way.
Yeah, and here's Melissa and I's email addresses. Just so you know, I probably will not be personally responding to all of your email because we have a team of amazing folks who know this stuff actually better than I do. But if you email us, this is also a little dinosaur QR code we got here. If you want to learn more a little bit about HR1 and how to stay informed. But we also have public provider meetings that you can join. We also have smaller meetings, like again with COPA, with some of our trade organizations. If you're interested and you're like, hey, listen, how do I get involved? We've got office hours, and then we also have a whole bunch of trainings that we've created. Okay, let's move on to some new questions, and I'm going to try to go fast. All right, let's go with, do you have a, can we, huh?
Hi.
Okay, there we go. Let's go.
Can you explain the expansion populations and
Yes.
then what's the first date we might see those changes of their coverage?
Okay, so what's not happening is the eligibility outside of work requirements, being eligible, what the federal poverty line is not changing. So in Colorado, the way it works is if you are a person with a disability, so you qualify for certain home and community-based services, or if you're a child or a pregnant person or postpartum for 1 year, then you are on Medicaid based on kind of your status. The income eligible population, that's your expansion population. And what that means is that you are on Medicaid solely because your income allows you to be. So on Medicaid, it's like 138% of the federal poverty line, and that goes by household. So in Colorado, for a single person, it's like $21,000 a year. If you make more than that, apparently too wealthy for Medicaid. So it's already a very low number, but when you have a larger household, it does go up. So a household of 4 is more like $48,000 a year. Okay.
Hi, thank you.
Yes.
So for everybody on Medicaid who is working, and I think that's a lot of people.
Yes.
These are really just paperwork requirements. And one of the solutions I would have loved to have heard you talk about is helping those people fill out their paperwork and make sure they can continue to get benefits, so all these providers around here can continue to serve them. What is in HCPUF's planning around helping people get through all the red tape and all the paperwork requirements, those who are working and should be eligible?
Yeah, so what we're trying to do, again, this relies on our federal partners being consistent in their feedback, which we haven't experienced. But there are a lot of circumstances in which, like, we have tax information, we have DMV information, we have SNAP information. We're able to, what we're trying to do as much as possible is create a program by which, like, we can get information in about a person. So we saw what happened in the PHE-1 when we were not prepared. We lost a lot of people who were eligible for Medicaid and who were not able to retain their Medicaid. So we're trying to say, like, okay, these are the people, not a single pair of human eyes have to go on that. This is all of they don't need to fill out a bunch of hand-done paperwork. They don't have to upload anything. It's all information that we can pull from existing data systems. The problem is we don't have a data system that says somebody's working. We don't have data systems that says somebody's in school. We definitely don't have any kind of data system that says this person is in a volunteer job. And so where we're kind of in negotiations, I would say firm negotiations, and you can ask Attorney General Weiser about how firm those negotiations look, right? He's been a great advocate for Colorado and making sure that we're protecting the lives of Coloradans. We're trying to say, listen, we can attest. We can do an attestation. Or we're gonna try to do like one form. But the problem is anytime you require human eyes to be on something for eligibility, you're gonna double the amount of time, again, every 6 months instead of every 12 months. So we're doing our best to use technology here, but it's a balance of not trying to overly rely on technology, like it's not AI, it's just regular like scanning technology. And so that's what we're trying to do our best to do is attestation. What our goal is to have an attestation model where you can say, yes, I did it. And then if we have an audit, we're gonna have to come back and say, hey, bring us your papers that show that you did what you're gonna do. And we're gonna have our certified application sites and folks do it. But to the extent that you guys can say, hey, listen, save your payment receipts, get a Google Drive, you know what, and I'm not, whatever, Google Drive, whatever one you like. But like, get something to save this information because it's gonna become as important as ever to show that you were volunteering, that you were at school. And if you ask me right now where my transcripts are, like I couldn't tell you. You know, and so like you need to be able to make sure you're helping people with that. Okay.
I got you next. So I'm really glad that I'm following that question. One of the things that I'm really curious about is in what way can we decolonize that system of attestation so that we can qualify like harm reduction programs and other community volunteers so that we can reduce that barrier to entry for folks who would otherwise be eligible. And we heard, like, there were great stories today, 9 years of recovery, and the shortest and most expensive part was enrollment in an actual treatment program. And so we know that treatment is a long road that doesn't just finalize in that in-person program. Thank you.
Yeah, so I think I'm hearing you that one group that's exempt from the federal work requirement rules are people who are in substance use treatment. What does that mean? So that's where we're supposed to define it. Right, this is where we are going to need some help. There will be some kind of, we think, a rule that's gonna show up. So I'm gonna need your feedback on this rule to say what it looks like. And I think, because the hard part is, you have up to a year that you can bill Medicaid. So is it like the day you walk in? We don't know when somebody walks into a treatment facility, right? So what does that attestation look like? How do we work with the provider community to get that? As far as decolonization, I mean, Medicaid is a system that was created in 1965. We still have a lot of work to do. And I just want to thank you all for all of the wraparound support that really the substance use community consistently shows up with where Medicaid still falls down, right? The inability to pay for harm reduction services, the inability to pay for recovery services outside of a clinical model. Those are still federal limitations of what we have, and that's where I rely on you all and hopefully the BHA and hopefully our philanthropic partners to help cover that gap because it still is very real. Do we have a microphone somewhere? sometimes it takes, I think, 3 seconds. Now we're on.
There we go. I do think that you covered a lot of what I wanted to ask, but I just want to make sure that I have like clarity on it. So I work for permanent supportive housing vouchers supporting a lot of folks. And when you talk about the volunteer opportunities, a lot of the people I work with are not they're not going to be exempt, but they are also not going to be able to work. And so who's going to define what a volunteer opportunity is? Because I mean, aside from my folks, like there's just not enough, right? There's not enough volunteer opportunities. And so who gets to come to the table and help decide what qualifies as a volunteer opportunity for somebody who might not be able to work?
Yeah, we believe that the federal government is going to be putting out some rules in June of next year for that. I would say, I would never suggest to a group of people such as this that your voice doesn't matter. I will say your voice is much louder when it's organized through a national advocacy coordinated campaign, right? When it's like, hi, well, okay, not me, because I have a title that says that I'm part of the Medicaid system, but like, if you have, as an individual, you're like, hi, listen, I'm Sharon, and I have feelings about this, and I think that you need to do it this way. Somebody will read it. It's not going to show up, though, in the federal rule changes. If you want to get into federal regulatory advocacy, you're probably going to work with a large national company that, like, does this. So, National Council of Behavioral Health and Wellness, the provider associations, nurses associations, social worker associations, recovery associations. There are some new ones like Shatterproof, Inseparable, people who have boards with people who used to be legislators. Those are the kinds of folks who they go and they pay for somebody to advocate at the Capitol. Those are people worth connecting with, and there's usually a Colorado version of that, Mental Health Colorado, for example. So looking at those organizations can be really helpful to get your voice heard, but it's tough. And to the extent that we have it, again, we're going to have public meetings at the state level, but it might not be our choice.
Hey, Kristen, I think we have time for one more question, which I know there's a lot of hands, but somewhere over on this side of the room.
Okay. Yes, sir.
Hi. I think a lot of my questions have already been answered, to be honest, but I just want to advocate for the fact that we see these people turning their lives around, right? And they're getting jobs and they're working and they're becoming productive members of this society and paying taxes, and then they lose their Medicaid 90 days into their recovery path outside of a detox or rehab facility. They reoffend. They end up back in the court systems, back in the prisons, and back on the streets. And then it's like homeless shelters, and we're starting the process all over again. So the biggest thing is like, how do we encourage people to work, but they're going to lose their Medicaid so they can't even get treatment? By the time they have a therapist, they can't even get it paid for by the state. And these are people that are doing what they're supposed to. Mm-hmm. So like, how do we advocate for those people? Like, where do we go as a community to like stand up for them?
Yeah, I mean, I'm going to say like when it's time for, thank you, yes. Absolutely. Well, and I mean, that's just a very human way to see it. Like, this person is trying to get back on track, trying to get it so that they can maintain independence, trying to get it so that they can have economic security again, which addiction takes away from many people, right? And so I think that the goal is to have a state definition, if it's possible. Again, we are going to advocate to the greatest extent possible in this Polis Primavera administration to say, can we recognize that because it can be 365 days till somebody actually gets a bill to Medicaid, that we can have a recovery organization or a provider attest? Like, could they sign a form for you? Could we get some kind of, so we're looking into lots of options, but I think the definition of what does it mean to be an SUD treatment is going to be essential. And so we'll make sure that we're sending out through the Opioid Abatement Council opportunities for engagement in that, because to me, maybe it is within 12 months of, any single bill that shows up in Medicaid, you're covered for 12 months for SUD treatment. That would be great. But I don't know if that's possible. Yeah, that's great. That's great. Okay, so Melissa and I will stay up here for a few minutes. Time's up, start to wrap up. We're at time? Okay, I want to thank you all for being here. Go on the QR code to learn more. Email Melissa and I if you've got questions.